The latest news, updates, and more from the world of health and medicine. This is Medical Minutes with Wish TV's medical reporter, Dr. Mary Gillis.
From Wish TV, I'm medical reporter Dr. Mary Gillis, and this is Medical Minutes on the All Indiana Podcast Network. Another COVID-19 mutation has been identified in 26 states across the U.S. Scientists call it the BA.2 variant, also known as the stealth Omicron, because it is difficult to detect with the nation's current testing capacity. Researchers have likened it to the fraternal twin of Omicron, but with one significant difference. BA.2 has 60% more mutations than Omicron, which had, until now, the highest number of mutations to date since the pandemic began. Omicron has over 50, BA.2 has 80 and counting. In this week's episode, I speak with Dr. Brian Dixon at the Regenstrief Institute about the possible threat BA.2 poses to the nation. Our conversation is next. Well, it is so nice to see you. I really appreciate this. Always great talking to you. So this new subvariant of Omicron came out of nowhere, it seems like. I mean, what is it? Detected in 40 countries, 26 states, just happened so quickly. Just your reaction to the rapid pace of this sort of developing, or maybe, I mean, it was in Denmark first, or maybe it just hasn't been on sort of our radar in the US. I don't know.
I don't think it's been on our radar here in the U.S. So it was actually detected in the U.K., I believe Scotland, way back at the beginning of December. So we've known about it for almost 2 months. So this is not something that is brand spanking new. And it is really sort of a natural evolution of, variants. So just like variants themselves are different from what they evolved from previously in terms of the alpha or all the other strains of COVID that we've seen, this new kind of strain of SARS-CoV-2 is really a natural mutation from the Omicron as we know it. So there's two types. There's BA.1 and there's BA.2, right? So this new subvariant is BA.2. We have known about it. It has sort of slowly spread in multiple countries, and now it is beginning to take over as the dominant strain in Denmark, which is, I think, what has people concerned because it's overtaken BA.1 in that country and may take over in other countries as the dominant strain of Omicron.
And then, just to put in layman's terms, a subvariant is what? A cousin, just so we can put that into perspective when we talk about a subvariant. Yeah. Genealogy of a...
Exactly. That's exactly right. So this is part of the Omicron family tree, if you will. In this case, it would be more like a son or rather than a cousin per se of BA.1, they could actually be sort of siblings if you think about the fact that both of them evolved essentially from a very similar strain a long time back in sort of the genetic history of this. So they're closely related to one another. They share a lot of the same sort of factors. There is one difference, and that is the difference that has some people concerned, and that's what has got it the nickname of kind of the stealth Omicron. Right. So it's known as stealth Omicron, and the reason for that is that when we do a PCR test, we can detect whether this is SARS-CoV-2. PCR tests, they're still going to work to detect this as an infection of SARS-CoV-2, but there is a mutation in the spike protein for Omicron that allows people to identify it as Omicron without having to do more sophisticated genetic subtyping. This stealth Omicron, it is missing that mutation that allows for easy identification of it being Omicron. So it's still going to show up when they do the nasal swab that you are infected with COVID, and so you're going to have to take all the normal precautions. It's not going to, fake out the antigen test or the test that the state health department does. It's still going to show up as positive. It's just a little bit harder to detect whether it is BA.1 or BA.2 unless you do the more sophisticated genomic sequencing.
Right. So I'm thinking that maybe this could be an underestimation in terms of, and it could affect the data tracking in terms of maybe if this, I don't know if it sort of could overtake. We don't know yet. It's really too soon to kind of see what this is yet. But, it's sort of like I was thinking about, like, if they're not identical twins, but they're fraternal twins.
That's a pretty close analogy. Yes, that's exactly right. Because they're going to have some differences in terms of as they grow up, if you will, and they're going to have differences in the children that they have later on, right? Their children are not going to look quite as similar as what we would expect if they were identical twins.
This, I was reading about some these spike proteins. It says 80 for this one, this subvariant. 80 sounds compared to the 50, and are they all in it's not, because sometimes it's right, it's in like the nucleus and it's not really something, it's the spike proteins, like, or you have all of these 80 sort of mutations, but the mutations aren't necessarily on the spike protein. So can we talk about the differences between Omicron, the 50, but they're not all on the sort of the outer layer versus what we know now in terms of the outer layer of this subvariant?
Yeah, I think the main difference is that there's some speculation that the composition of the subvariant makes it more transmissible. And I think that's what some people are concerned about, because obviously if it's even more transmissible than, Omicron 1, if you will, then it's going to spread like wildfire in a population even more so than Omicron 1. But to be honest, Omicron is so transmissible that it's moving rapidly through the population already. And so it's unlikely that this variant would be any sort of more deadly or cause more severe disease. So in principle, both of these types of Omicron are going to be similar in terms of their impact. At least that's what the initial data show. And unfortunately, outside of Denmark, we don't have a lot of data on the severity of this new strain. However, the data that we do have available does not suggest it's more severe, which is why the WHO has not classified it as a variant of concern.
Right. I mean, I was sort of looking at something and they say the cases are on the rise, which is something to be sort of pay attention to, but it's not yet. We don't know enough about it, considering, right, just yet it's too early to know, and more research.
Yeah, so obviously as this new subvariant begins to work its way through populations in multiple countries, so we know it's already in multiple countries, it will continue to kind of spread as people come into contact with one another. Then we can do some analyses to sort of compare it to its fraternal brother, Omicron 1, and see if there's any difference between them in terms of severity and in terms of the symptoms. But we are expecting, based on the genetics, that the symptomology will be similar and the severity will be similar.
Yeah, I mean, it seems like if you have your dose, you have your booster, maybe you've had natural immunity. It doesn't seem like it's anything to be super concerned about right now. I mean, it's just striking to say 80. That's like not double, but so I mean, your reaction to that. I mean, if you have your dose series, if you have your booster, maybe a layer on top of that of natural immunity, or maybe not. I mean, let's not strike fear in people, is what I'm saying.
That's right. I don't think there's any reason for people to panic over this new subvariant. I also don't think that people should fear it more than other strains of COVID-19. So especially if they've been vaccinated, we continue to see in all the various waves since vaccines have become available that the vaccines are effective at reducing your risk of severe disease, hospitalization, and death. And we would expect that the vaccines will continue to perform well with these new subvariants and future variants. That's always the question. And so we're constantly looking at that. But the data we have so far on Omicron would suggest that the vaccines are working effectively, especially if people have been boosted or received a third dose. So individuals who have, immunosuppression disorders, they definitely, need a third dose, and that's holding up if it was recently given for those individuals in that group. Similarly, with older populations who are at higher risk of hospitalization, who received a booster, they are also seeing benefits of that during the Omicron period. So we saw good performance in Delta. We're seeing good performance now with the boosters being in effect. So we would, of course, would encourage people who haven't received the third dose to do so in order to protect themselves. That's the best way to protect yourself, especially as we continue to learn about some of these drugs, these treatments on the market that are not as effective against Omicron. So that would be the concern, is that individuals who were planning on getting a treatment after they become infected are beginning to realize that only some of those treatments are effective against Omicron. The best protection that we have are the vaccines to dramatically reduce your risk. There's always going to be a risk of hospitalization, but it's much lower, like on the magnitude of 20%. The effectiveness of the vaccines is like 80%, right? So it reduces your risk by 80% if you've been boosted. If you haven't been boosted, you just have the 2-dose series, we're seeing, effects of like 40 to 50% reduction in hospitalization, which is still good, right? That's about where the annual flu vaccine typically is. With the booster, you're increasing your protection.
Are we talking about I just want to go back to the treatment. Are you talking about the monoclonal antibodies and the molnupiravir? Are we talking about we're not pushing those as much because the evidence suggests that they are not as effective as the vaccination, or even if someone is vaccinated and then they get let's say a breakthrough. I just kind of just thinking out loud here, but is that what we're talking about?
Yeah, those are the drugs exactly that there's evidence that they're less effective against Omicron, and so that would suggest that physicians would be turning to other treatments, right, for patients, and those drugs may not be a lifeline as much with the Omicron variant as they were with Delta and prior strains.
If we're seeing this, Dr. Dixon, about these, the original series that we have of dose series plus the booster, we see there's an Omicron specific variant vaccine underway. I mean, I don't understand why that's necessary.
Well, a lot of us in public health are not convinced that the Omicron-specific vaccine is necessary. There isn't enough science yet to suggest that we definitely need an Omicron-specific one, because what's likely to happen over the next year is that there's going to be a new strain that would emerge based on what we know from all other diseases. So it's unclear that the Omicron-specific one will be it'll probably be effective against Omicron, but it may not be effective against future strains. And so, therefore, we're not sure it's a worthwhile investment to get the Omicron-specific one at this time. Well, and it's going to be months before it's even available. So it's not like you can go out and get it today. I guess if it were here today, it probably would be worthwhile. But when it comes out probably this summer, Omicron may be displaced by something else.
I mean, things are changing every minute. So absolutely looking down the road. So no, I was talking to other doctors about this, and they were saying, "Oh, this, it's preparation is here. It's good to get something started." And I was just really curious. I think to the point you were speaking to, that if these vaccines are working with Omicron, and then we develop something specific to Omicron, and something completely changes, as it has been, previous behavior, previous events kind of, I don't know, are predicting future events here as we've seen. But anyway, I just kind of.
It would probably make more sense for vaccine manufacturers to begin to move towards a process much like the flu, where each kind of annual dose, if you will, that gets manufactured is a combination of strains, such that, we kind of try to anticipate what will be the strains for that year in order to protect the most people that we can. So it would be more like adding essentially Omicron to the mix as opposed to an Omicron only type of vaccine.
Well, because that leads to the question, do we need this Omicron shot? Do we need the Delta shot? Do we need the Lambda shot, even though it's Lambda, beta alpha are essentially been abolished But no, that's a great point. I mean,
I think eventually we will all need annual boosters against coronaviruses, because we already know that there's 4 other types of coronaviruses that cause the common cold. Now, those coronaviruses don't typically put people in the hospital. However, SARS-CoV-1 and SARS-CoV-2 both do put people in the hospital and cause people to die and have severe long-term consequences. We're seeing long-term effects from COVID. And so in order to protect us going forward, we anticipate that there will be some regular booster. We're guessing right now that it will be annual. It could be, every couple of years, but the science has yet to determine that. But at least for now, we certainly would anticipate that vaccine manufacturers would update the vaccine to add in protection against future variants, and then most likely will become a steady state where we see regular boosters like we do for the flu and shingles and other diseases.
So just going on, just thinking about, what you're saying, just curiosity. I think sometimes I think about, just through these years of, first we have one vaccine is effective and then the antibodies wane and then we need another one and then we have our booster and then we might need a 4th shot. And for those immunocompromised, of course, the data shows that they are 30%. I think it was 30% at one time I was talking to a transplant doctor, do not develop any antibodies. 70%, it's not enough. But then I also think about vaccine dependency, because I know, antibodies are one, and I know it's too far. We don't know what's going to happen yet, but I think about that, meaning, there's like a militia of metabolites underneath those antibodies? Like antibodies is one layer to protect. And is there such thing as that, vaccine dependency? And if so, is it something that could help us, or is it something that could hurt us?
Well, if we're too dependent on vaccines, it may actually hurt us in the long term, because then you'd have to continuously be getting shots, right? To kind of thwart whatever new thing, and you have to be constantly updating the vaccines to account for new genetic mutations. So eventually, I think what's more likely to happen is that over time, as people become exposed to SARS-CoV-2 and its various versions multiple times, that the population as a whole will have some memory against it, just like we have for other diseases. So that means that in the future, that it's more and more likely that only some populations will continue to need extra doses or boosting, if you will, like the immunocompromised, like people who are over 60 years of age, etc., because they're at these higher risk groups. Just like today, we don't recommend that everybody get a shingle shot until you're a certain age. We don't recommend that you get, other types of vaccines unless you're going to be traveling to an area that's endemic to them. It will become those will all be guidelines that will be developed over time as we sort of evolve and move into what we're now calling the endemic phase of COVID or SARS-CoV-2.
That I think that would put sort of a lot of relief in people in terms of that, because it is possible you kind of compare what you're saying is, from what I understand, comparing it to the way the flu strains, and we try our best to sort of formulate what we think is going to happen, and having that also with the coronavirus eventually. The flu's a coronavirus, right? So the coronavirus, we kind of know how to do that in a sense, but just not quite yet, because we're not there yet.
Right. I think that's the thing, is that, scientists and public health experts are kind of debating that right now, is will Omicron push us into the endemic phase? There's not enough data to say definitively yes or no. So it's right now kind of a scientific debate that's happening in real time, right? So if you're watching it live on TV, it can be a little confusing because you're like, well, is this going to be the end of it, or do we need another year? So it depends on which expert you talk to. So that just tells us that it's a little too soon to go fully back to normal. So we're going to continue to need to take precautions, especially for those high-risk populations. I think that's what gets missed in some of the conversation. If you're a very healthy 25-year-old that has had COVID and you've been vaccinated since then, you're probably in pretty good shape, but we don't want you to just go around and infect other people, because there are still populations that can be devastated by this disease. And there are some pockets of people who've taken a lot of precautions for the last 2 years, and they're still, very vulnerable to this. So we really need more time to essentially get the whole population, at a place where we can truly move back to normalcy. And that may come later this year if some experts are correct that this is the, Omicron's going to help us get there. But there's a lot of scientists that say, well, there's a good chance that another variant will emerge this summer, for example, in some part of the world, because that's the thing, is this virus is everywhere and it's being exposed and mutating as it goes through not only humans but also animals. And so that's the other part of the equation that we have to continuously monitor. So the good news is that if you are, right now, if you're vaccinated and boosted, you have some protection, which allows you to at least feel confident in going about most of your daily activities, maybe with some precautions like continuing to social distance and using masks, at least over the next month or so until we're kind of through the Omicron wave. Then we will kind of see what happens, and we can sort of reevaluate whether we go fully back to normal or we continue, I think, always to maybe be cautious of these types of diseases. And some time of the year, we use masks on a regular basis, for example, just to protect ourselves from respiratory diseases. And then other times of the year, we know that they're not as necessary and we may not need to use them.
Well, that it's interesting because this science, could be two schools of thought, and it really just depends on who you're speaking with, and having those conversations between those scientists, I think, is really important. Even though, it's like Aristotle, it's art of an educated mind to entertain a thought without accepting it. But having those conversations, like, I see what you're saying. I don't know. I kind of miss science in that way at times. I wish there was more conversation, but that's just a side note. And then, oh gosh, I had another question for you. That was so interesting what you were saying. Gosh, anything else you want to add about this, BA2, this, what's happening now? Your message.
I would say for my message to kind of, to all the citizens, essentially, public health is watching. We're monitoring this. At this point, there's no concern for alarm or fear or panic over this new subvariant. It acts and, from what we can tell, talks like the other form of Omicron that's out there. And so it just, if anything, it means that we need to continue to be cautious for the next little bit while we wait for Omicron to kind of wane down, and we can then move on to the next phase of this pandemic.
Mm-hmm. Can I ask you one more question? I was with a publicist yesterday. We were doing a story unrelated, and she was talking about a reporter who came to her. She was looking for someone to say, when is this going to be over? And the publicist used to be a reporter here. And she's like, well, we can't get someone to answer that for you. It's just, we don't know. We have to just keep following. I mean, I wish there was an answer. I wish you could, get the magic 8-ball or anything, or but I am not asking you that question. So yes.
Yeah, well, we have just like with weather forecasting or anything else, we have a crystal ball, but it only goes out a couple of weeks. It doesn't really go beyond that with any accuracy, and so it's very hard to predict. But I think that there is consensus building towards we need to figure out how to live with SARS-CoV-2 by the end of 2022. So by the end of this year, I think we will have enough information that we can then, have some reasonable guidelines of how organizations should, treat this and requirements for populations. We will have, more, I would say, relaxed measures when it comes to policies like masks on airplanes and other venues. We will have kind of more of those normal like things like pre-COVID like activities and behaviors start to come back, because we'll start to figure out how to live with it. Because again, right now, even though Omicron itself doesn't necessarily cause more severe disease than prior strains, we still have a very overloaded healthcare system. And so one of the fundamental questions we have to figure out is, how do we live with Omicron and take care of those patients given where we are with staff and facilities and insurance and all of those other parts of our healthcare system? We have to figure out how to manage that going forward. And I think that's the piece that no one's really talking about that, but that's the piece we really have to figure out before we could truly ever get back to normal.
Right. I mean, I feel like this has kind of like turned our healthcare system upside down, and the huge overhaul is going to be necessary. But by this time, there's a lot going on. Again, it changes, but by the end of 2022 sounds like a good benchmark. So hopefully, cross our fingers if that's the case.
Yeah, I know the only thing that keeps us from like really marking that in the sand is the concern that a new, more virulent strain, will appear, and so that's the only hesitation we have. But there's always a risk of that, but only time will tell until we get there.
This has been Medical Minutes from Wish TV. I'm medical reporter Dr. Mary Gillis. Be sure to follow and subscribe to this podcast and check out new updates every week. You can also learn more at wishtv.com and when you follow Wish TV on Facebook.
Learn more and get more with Wish TV. Online at wishtv.com and when you follow Wish TV on Facebook. Be sure to check out more great podcasts from the All Indiana Podcast Network now at allindianapodcastnetwork.com.